All right, I have 12 o'clock over here, so let's go ahead and get started. I want to welcome everybody to the University of Colorado Medical Grand Rounds. Announcements for today. I think the biggest announcement is obviously COVID is unfortunately still reigning supreme. As of January 7th, the campus has declared an ACGME emergency. That if anybody has questions about what that means, feel free to ask me, but it does mean that there's a possibility of resident and fellow reassignment to help out with the busiest ICU and hospital teams, much of which has been going on voluntarily. This will allow us to make a few more additional moves. So that's a change for the campus that will last for at least 30 days and likely up to 60 days. The second announcement is that all grand rounds this year are eligible for CME and mock points. So please use the link put in the chat by Kelly Redard. Third announcement is please use the Q&A feature for all questions. The chief medical residents and myself will gather those questions as the talk goes on and make sure to ask them of Dr. Pomfret and Dr. Jackson at the end of the talk. Now it is my pleasure to introduce our two speakers today. First is Dr. Elizabeth Pomfret. She is a professor of surgery. She is the CAM Endowed Chair in Transplant Surgery, Chief of the Division of Transplant Surgery, and the Executive Director of the Colorado Center for Transplantation Care, Research, and Education. She was a medical student at Boston University, where she graduated cum laude. She was an intern, resident, and chief resident on the Harvard Surgical Services at Deaconess Hospital. She was also a hyperalimentation fellow, as well as a fellow in multi-organ transplantation, also at the Deaconess Medical Center in Boston. She's incredibly active in all major surgical societies. She is truly a world's leader in transplant medicine. She's published over 100 original manuscripts during her time as an attending surgeon. She's also given an equal number of talks nationally and internationally. She's currently the PI or co-PI on 7 active ongoing trials and has the funding support to match. Her collaborator today and in life is Dr. Whitney Jackson. Dr. Jackson is an assistant professor of medicine here at the University of Colorado in the Division of Gastroenterology and Hepatology. She was a medical student at Jefferson University in Philadelphia, where she also completed her internship and residency before moving to the Cleveland Clinic, where she did her fellowship training in gastroenterology and hepatology. She returned to the East Coast to complete her advanced fellowship in transplant hepatology at Columbia University, and we were lucky to recruit her to the University of Colorado in 2017. She is also internationally renowned for her work on living donor transplantation, speaking locally, regionally, nationally, and internationally, with the exception of a trip to Turkey that was canceled during the pandemic on the same subject. Her work is well supported by the NIH as well as by Donor Alliance, and it extends not only for living donor work, but also through the clinical sciences around NASH, the use of cell-free DNA to detect liver cancer, as well as really impressive work on health disparities, as well as gender disparities in liver transplantation. And now it is my pleasure to turn it over to Dr. Pomfret and Dr. Jackson.
Thank you so much. What a kind introduction.
Thank
you. So I'm going to start today by showing you a video. The reason I want to do this is because I want to maintain the classic format of a grand rounds, although I recognize it's so limited with the technology that we have to be using these days. So I thought a video to demonstrate our patient stories is really the best way to do that. And they just tell their stories so eloquently. So it's about a 5-minute video.
As Americans is far stronger than what divides us. This morning, we introduce you to Rebecca LaSalle, who gave the ultimate gift. One of her organs saved the life of a 1-year-old child. Now, unlike most of the 8,000 liver donors in the U.S. last year, LaSalle didn't know, or she didn't care either, who received that gift. She simply did it because she says she wanted to help somebody else. Barry Peterson was there when she met the little boy she saved. And in a moment, you'll see only on CBS This Morning.
There is joy watching an 18-month-old discover the world. But for Manolo Gonzalez, these moments might not have happened. Shortly after his birth, doctors discovered that Manolo had a life-threatening defect causing his liver to fail. He was lethargic and wouldn't eat solid food. The only cure was a transplant, and 6 months ago, he got one at Children's Hospital, Colorado. Samantha Gonzalez is Manolo's mom.
What happened and how fast did it happen after the transplant?
The moment he woke up.
Really?
A complete 180. He was ready to eat same day. He was ready to start crawling.
What saved Manolo was a decision by 24-year-old Rebecca LaSalle, a complete stranger living 700 miles away in Montana, who decided to donate part of her liver to anyone who needed it.
I merely just wanted somebody else to live.
Without even knowing it wasn't your brother or your cousin or anyone, it was just a someone.
Just someone.
Because?
Because nobody deserves to suffer.
Rebecca is what doctors call an altruistic donor, meaning she gave a part of an organ without specifying who would get it. And this was her second time. 2 years ago, she also donated a kidney. But the liver transplant is a far more difficult and risky operation.
There's very few people in the world who have donated part of their liver and a kidney.
Dr. Elizabeth Pomfret removed part of Rebecca's liver at the University of Colorado Hospital. She says living donor transplants make up about 4% of all liver transplants done in the United States each year.
Of that 4%, the number of people who are altruistic donors is extraordinarily small.
But with altruism comes a healthy dose of skepticism.
So she was also evaluated by a psychiatrist and a social worker and a nurse coordinator.
So she really almost had to talk you into this.
In some ways, yes.
What convinced you?
It was her demeanor and her passion and her conviction and her maturity. Let's just see.
Rebecca recently returned to the hospital for a 6-month checkup.
Hi.
And for the first time met Manolo, the child she saved.
Hi. It's nice to meet you. Hi. This is Manolo. Hi.
Life-saving for Manolo, life-changing for Samantha.
At that time, I was going through like a really hard time with his dad and with what was going on with him. I lost faith in any kind of good person out in the world.
He saved my life. So the fact that you saved his, there's no words I can express to you how thankful I am for what you've done.
If what she did is extraordinary, why she did it is even more impressive. And it all goes back to a lesson her mother drilled into her every day.
Before I could walk to school when I was a little girl, she would say, make the world, and you had to say a better place, and you'd always groan it out. But it was something that actually she did instill in me, and I do want to make the world a better place.
Mom was right.
Yes, Mom was right.
Not only does that explain Rebecca's inspiration,
I don't ever want you to have to feel indebted or feel like you have to say thank you because he deserved it.
it also explains the emotional letter she wrote for Manolo to read when he grows up.
Most of all, I hope that this opportunity will inspire you to help others to make the world a better place. Oh, my love, Rebecca.
So this is a story that may never end, because there are many more good deeds yet to come. For CBS This Morning, Barry Peterson, Aurora, Colorado.
Well, we're very happy to report.
So that's just a nice way of our patients introducing the topic and just showing what a huge difference that they've really made. So I do just want to say thank you so much for having us here to present Grand Rounds today and our experience of living donor liver transplantation and the rise of altruism here at the University of Colorado. I do want to dedicate the talk to Hugo Rosen, our prior chair of gastroenterology, who really is the reason that we're here. He recruited us in 2016 separately, obviously, we're not married. So our hope is really that this talk can remind us of really just the positive side of medicine and how many amazing things are going on despite everything that people are going through these days. We don't have any disclosures. Just as an introduction, living donor liver transplantation is the process of surgically resecting a portion of a healthy person's liver and placing that healthy piece into someone whose liver is not working. Their cirrhotic or non-functioning liver is removed fully first, and the pieces of healthy liver are regenerated both in the donor and the recipient. Living donor liver transplantation was born from pediatrics. It was pioneered by Dr. Chris Brolsch and his team at the University of Chicago. This is a picture of Alyssa Smith. She was the world's first living donor liver transplant recipient. And this is a picture of her graduating from high school in 2006 in Texas. She was transplanted at 21 months of age for biliary atresia, and her mother was her donor. Now, at the University of Colorado, our history started even prior to that in transplantation. Dr. Thomas Startzel performed the world's first liver transplant here. And Dr. Eagle Combe trained under Startzel at the University of Pittsburgh and then restarted the transplant program here in 1988. And it was really under Dr. Combe that the transplant program was established here and thrived. He and his team, much of the same surgeons that are still here currently, performed the world's first successful adult-to-adult right lobe living donor liver transplantation in 1997. And Dr. Combe then chose Dr. Elizabeth Pomfret as his successor in 2016. She brought with her the country's largest living donor liver transplant experience from Leahy Clinic. She had trained under Chris Broch, and who was the surgeon in Chicago with those pediatric patients. And I believe, Liz, that honestly part of your legacy is going to be that you will have developed the largest known non-directed living donor experience in the United States, and that you've really been a champion for pediatric liver transplantation. So the University of Chicago is one of 6 high volume centers performing 20 or more donor hepatectomies a year, which really just goes to show that we have an expertise in this as well as our history. And our learning objectives today are going to be to understand the role of living donor liver transplantation, to review the ethical principles of living donation and the surgery itself, and also to illustrate the impact that our non-directed donors have had on the program. So I just want to give you a case example that we see from the adult side, not infrequently. So Raynette is a 50-year-old female with autoimmune hepatitis and cirrhosis. She has complications of recurrent ascites and hepatic encephalopathy. Her MELD sodium is 15, and she's blood type A. And so we think that she needs a transplant, but her MELD sodium does not even place her in the top 10 in terms of medical urgency and priority in our country for a transplant. And to give you some background on the MELD, well, MELD sodium predicts a 3-month mortality in patients with liver disease. Sodium was integrated into MELD in 2016 because it was shown to be an independent predictor of mortality in our cirrhotic patients. You can see that a MELD of 26 carries a 20% 3-month mortality, while a MELD of 40 is associated with a 90% 3-month mortality. But while MELD remains predictive of mortality, we know that MELD has its shortcomings, and MELD is really not always enough for our patients. One example of this includes our patients who have portal hypertension. So a patient with moderate ascites and a MELD of 11 actually has an equivalent risk of death as a patient with no or small volume ascites with a MELD of 16. We also know that sarcopenia is associated with mortality and that women are disproportionately affected. You can see here the decreased comparative survival of women on the wait list, as well as the dotted lines showing our lower survival for patients with sarcopenia. Notably, you see here the dotted red line where women are severely affected more than men. So if MELD isn't enough, and a lot of our patients are sicker than our MELD, I want to show you this paper by Marion, which is really a seminal paper that is popularly quoted quite often. You know, when should we be transplanting our patients? So he tried to define an inflection point at which the benefit of transplant outweighs the risk. We know that liver transplant is a major surgery with its own risks. And from his work, really the transplant community continues to point to this MELD of 15 as the time to pursue transplant in our patients. Now, that paper was written in the early 2000s. It was when hepatitis C was still not able to be cured. It was when living donor liver transplantation was still early on. And so our group recently looked at the same question, but with updated data, and asking at what point, at what MELD, do the benefits of transplant really outweigh those risks? And we're really able to show that a MELD of 11 is probably a much more appropriate point in time to be pursuing transplant in our patients. So just because I think that somebody needs a transplant doesn't mean that I can always get them a transplant. The wait list continues to reflect a limited resource. And so you see that this gap still remains. And the orange bar are the number of living donor liver transplants taking place in the country, and the blue is the deceased donor transplants. And so we still don't seem to have enough organs to help all the patients who are waiting transplantation. In fact, 1 in 5 patients dies still waiting for a liver transplantation. And so Raynette is listed, and I just want you to see what she's really up against here. This is looking at data from A2All. A2All is the adult to adult living donor liver transplant study group. It's a consortium of high volume living donor liver transplant centers. And really, we have most of our outcomes data on living donor liver transplantation through this consortium. The reason is because none of us are doing enough living donor liver transplants to publish data as a single center. We really need to pool that in order to have meaningful sample sizes. And so what I want you to note here is what's going to happen to Raynette. Well, her MELD of 15 sitting on the wait list puts her in these black lines over time. So the worst place to be is the wait list. Her probability of death is highest. And living donor liver transplantation, even for these patients with lower MELDs relatively of 15, do absolutely excellently. And the other thing I just want to make a quick note about is that the pediatric patients are also extremely underserved. So this is what Manolo was up against. The purple bar represents patients who are under 1 year of age. They have the highest pre-transplant mortality risk compared to all other children and adults. And the reason is really because they are small, and so they have to wait longer to get a size matched organ. And so these children specifically really benefit from living donor liver transplantation where they're getting a partial graft. We also know from A2All that short and long-term survival outcomes after living donor liver transplantation are excellent compared to deceased. They're probably equal, if not better. And this is true for pediatric recipients as well. And so lessons learned are really MELD sodium of 11 is probably the point at which we should be really advocating for our patients to get transplanted. Because we have all trained where we work in a system where our patient needs to be competitive for deceased organs, I think we live in a high MELD world, and we have to reset our thinking in terms of when is the best point to get increased survival outcomes for our patients. And living donor liver transplantation frees that patient from our current allocation system, allowing for independent decisions of what's best for our patients without having to compete with other patients. And our outcomes are better, if not equal, if not better than deceased donor outcomes at high volume centers. This is a picture of a commercial that actually aired nationally that was put out by UPMC, the Pittsburgh program. And the idea here is to get out of line. It's an educational advertisement that they put out to just show the advantages of living donor liver transplantation. You get to free the recipient from the wait list. They have the ability to get transplanted before they have a high MELD and are critically ill. They have improved recoveries. It increases the overall donor pool. So while it's helping your patient, it's also helping all the other patients who are waiting. It's a healthy organ, and the outcomes are excellent. And so next, I'm going to ask Dr. Pomfret to review the ethical principles of living donation and the surgery itself, which is the fun stuff.
Thank you. So we'll talk a little bit about ethics and then the surgery itself. Right. So the age-old question since living donor organ transplantation has been happening, whether it was kidneys or livers, is really, is there ever a scenario where there's an acceptable risk to the donor? And there was a Vancouver Consensus Forum, International Forum, that was held in 2005, and the publication came out in 2006, and I was part of the liver group of it. And at that forum, it really established both the medical guidelines that should be used for evaluating live organ donors that are not kidney donors, and the ethics. And we decided that in terms of liver, living donor liver transplantation should be performed if the risk to the donor is justified by an expectation of an acceptable outcome for a recipient. So that's a little wishy-washy. What's an acceptable outcome for the recipient? I think most people feel at least a 50% 5-year survival at this point is acceptable, but there are certainly other groups that don't utilize that. The indications initially were the same as for deceased donor. They've expanded as we've become more comfortable with living donor liver transplantation. So now we do tumors that would not be acceptable for a deceased donor transplant. And it should offer an obvious overall advantage to the recipient when compared to waiting. And Whitney just showed you that the most dangerous place is sitting on the waiting list. So there's a twofold advantage to living donor liver transplant. One is you decrease the waitlist death by about 50%, and the outcomes post-transplant are better as well. So there's this constant tension that exists between the principles that we always discuss in ethics of utility, non-maleficence, and beneficence. And utility is to promote the net good. So in other words, who needs this most? Beneficence, do good. So you want good recipient outcome. And then non-maleficence, do no harm, so donor safety. And that tension that exists is different in deceased donor liver transplantation versus living donor, because in deceased donor, you have a limited organ supply. In living donor, you're bringing the organ to the operation. So with deceased donor justice, you have to have all candidates having equal access to transplant and equity, applying the same principles for organ allocation equally. But it doesn't bring in the issue of autonomy. So, I mean, there are many, many, many instances where we've seen that people are willing to accept much higher risk than we as medical professionals. In fact, plastic surgery is a perfect example. I mean, there's certainly always a risk that you could have some serious complication or even die during a cosmetic procedure, but we don't, prevent patients from doing that because we think that that's dangerous. I mean, they have patient autonomy, and yet that has not been the same thing in terms of how we treat living donor liver transplantation. We have been much more parochial and quite frankly parental about saying, well, I don't know that this relationship is close enough to have this donor accept this risk. So that's where the ethical tension is. Every program has a protocol that they use. This is our protocol. A potential donor has to at least be 18 years old to consent for a procedure on their body, and less than 55 years old, because people start to have medical problems after 55 years old. But we know that liver regeneration is not as robust after 60 years old. So we kind of look at that 55 to 60 very individually. You have to have a compatible blood type, no major medical issues, no major psychiatric issues that aren't controlled. Typically a BMI less than 30 to 35. We've gotten a little bit more liberal with that. It's a 2-day evaluation. That's extremely labor intensive evaluation, includes lots of different tests, including imaging studies, and then meeting with a host of different specialties, including an independent donor advocate, a hepatologist, a surgeon, psychologist, dietitian, et cetera, social worker. And then any other additional testing that we end up needing to do because of a person's particular risk factors or family history. And then a final decision is made. We have a selection meeting every week. Everybody has an equal voice in that selection meeting. And a donor can withdraw from this process at any point during the evaluation, including up to the day of surgery. And I have had someone back out the night before surgery. So one of the things when we first started doing this that we really had to have better data for is really being able to estimate the size of the donor's liver, and in particular their right lobe versus their left lobe, and then being able to see the vascular and biliary anatomy overlaid on each other so that you can understand the relationship. And there's always a balance of risk between how much liver we take from the donor and leave with the donor. We know we have to leave the donor with at least 30% of what they started with. So we have this specific software. I've been working with a group from Bremen, Germany for almost 2 decades now, and they are able to make these 3-dimensional images for me, and we can manipulate them and then be able to figure out exactly total liver volume, right lobe volume, left lobe volume. And the estimates are about 8% higher than actual because of blood volume. So this is just a cartoon and then a life picture of what it looks like. We basically are splitting the liver open like a book. And the difference in this operation versus taking a right lobe out or a left lobe out for a tumor is that you can't interrupt the blood supply. So you have to go through the liver with the blood supply totally intact, because we can't have that kind of ischemic injury to the liver. And then you can see the cartoon on the right shows that the inflow is the right hepatic artery to typically the right hepatic artery of the recipient. The portal vein to the right portal vein to the portal vein of the recipient. That's the inflow. The outflow is right hepatic vein, typically to a new opening on the vena cava. And then we can either do a duct to duct anastomosis, where we connect the right hepatic duct to the common bile duct of the recipient, or use a loop of bowel, which is a hepatocegenostomy. So the biggest issue is really the risk associated with this operation. Unlike a kidney donor where you've got 2 kidneys, you're taking one out, the other one is obviously safe. You know, here we're splitting the liver, and there is the possibility of damaging the lobe that's not being taken, or having a catastrophic event and having the donor potentially die. And the risk is associated with how much liver tissue we take out. So just to give you a sense of what are we talking about when we talk about these different types of transplants, typically for an adult to an adult living donor transplant, we're taking the right lobe, or about 60% of a healthy person's liver. Left lobe is usually suitable for either a small adult, typically a small woman, or an older child. And then for an infant, we can use just a portion of the left lobe, the left lateral segment. And that's typically about 15 to 20% of the liver volume, left lobe about 40%, and right lobe about 60%. So the published literature shows that the risk of a catastrophic outcome, death or needing a transplant, for right lobe donation is 1 in every 200 donors. The actual data today is that we have had 7 people in the United States who have either died or needed a transplant out of about 8,700 donors that have been done. So it's much smaller than what's in the published literature, but I always quote this to potential donors. And the risk of complications is about 1 in every 3 or so patients. Left lobe is safer. The risk is about 1 in 1,000 for death or needing a transplant, and risk of a complication about 10%. So our goal is always to use the least amount of liver tissue from the donor, but it obviously has to be suitable for the recipient. So how do we influence this? Well, obviously program experience makes a big difference. We know from the A2All data that the learning curve is at least 20 of these procedures, and then the complication rate goes down significantly. The selection of donors and being able to appropriately pair a particular donor with a recipient is very important. And then obviously the extent of the donor hepatectomy. So now I want to talk a little bit about ethics. several years ago, I was on a panel looking at the ethics of using living donor grafts, liver grafts, for patients with hepatocellular carcinoma. Those patients who had small tumors versus large tumors versus, extremely large tumors. And this was work that I did with the ethics team at the University of Chicago. The concept of double equipoise is basically a balance between the recipient's survival benefit with or without a transplant and the probability that the donor could die. And this risk benefit analysis isn't just confined to, the donor and the recipient. It's actually a balance between the two. And the concept of double equipoise, suggests that there's clearly a zone where there's excessive donor risk, where almost everybody would agree this is not a reasonable thing to do. And there's also the opposite side of things, where there's an unacceptably low recipient benefit, where you'd say this doesn't warrant the risk to the donor. So we used that 1 in 200 incidents of death as what we would use as what is our ethically acceptable, a 0.5 to 1% mortality, and constructed an argument around that. So what we're doing in this is really trying to define the zone that's unclear between the extremes, where it's very safe for a donor because they're just donating a very small portion of liver, or it's unacceptable. And the question is really, what's the minimum benefit to the recipient that warrants the use of a living donor? And how is the use of the living donor for extended indications like big tumors or an old recipient, how is that benefit justified? So we came up with Mark Sigler, who is a very, very well-known ethicist from University of Chicago, came up with this diagram. And the yellow is ethically unacceptable. Okay, so either the recipient benefit is so small or the donor risk is so large that just about everybody would agree it's not reasonable. The blue is ethically acceptable. The recipient benefit is so high or the donor risk so low that pretty much everybody would agree that it's a reasonable thing to do. And the gray zone is obviously the gray zone. So it's describing the balance, the concept of double equipoise is really describing the balance between the recipient survival benefit with or without the transplant and the probability of donor death. So there's different types of donation. There's directed donation. I want to donate to my sister. There's non-directed donation, which is what you saw in the news clip at the beginning of this, where someone just wants to donate to somebody who's waiting for a liver. And that really brings up a whole nother dimension of the ethical argument, because in the beginning of doing living donor liver transplantation, everybody really agreed that you either had to be related to or have a very close relationship with the recipient if you were going to be a donor. But in kidney donation, we know that strangers donate to strangers all the time. So this issue of altruism, really came up, and we don't like to use the word altruism anymore because we feel that every donor is obviously altruistic. But when we were first talking about altruistic donation and whether that's reasonable, that was really stepping over the next line of ethical arguments, because there's no relationship between these people. So just, for the purposes of definitions, you see it here, some of the synonyms: selflessness, benevolence, kindness, et cetera, et cetera. So considerations for non-directed donor, probably the group that's really led the way with altruistic donors was the group in Toronto. And they were really the first ones to publish a series of altruistic liver donors and really pushed the envelope. And they found that there were certain features that were important for these non-directed donors. A history of altruistic behavior, that they were perhaps blood donors, routine blood donors, high level of motivation to donate, a logical rationale for donation. So we'll talk more about that. No expectation of a secondary benefit. They have to obviously understand the informed consent, no evidence of a high risk or of negative psychosocial outcomes, a willingness to maintain confidentiality. They have to hopefully have a supportive family and acceptance of standard organ allocation. And so this was kind of the rules that were used in the beginning. And some of those, I think, have lightened up as it's become more common. So again, for an altruistic donor, you're talking about no relationship. It's not like, I'm donating to my husband or what have you, and I've got I'm willing to take that risk because we have a child or whatever. So this is where this amount of liver tissue and the donor risk really comes into play. So right lobe, as I said to you, is typically adult to adult. Left lobe is for either a bigger child or a small adult, typically a small female, or for a baby. And so the way we prioritize how to allocate a non-directed liver is, the first thing we do is look at who has the highest chance of dying on the waiting list. Well, that's the small pediatric patients under 1. So the first thing we do is we look and see, is there any child who's of a compatible blood type, and blood type compatibility is less important in that first year of life. Appropriate size, degree of illness of the child. Is there any way that this child could get a transplant from someone they know? And so that's kind of our first group that we look at. If we come up with no one in that category, then we'll think about left lobe. Is there any 4'9" person sitting on our adult list who's been passed over and over and over because there isn't a suitable sized organ that's of a compatible blood type and has appropriate anatomy? And then if not, then we look at the rest of the adult list based on the size of the liver graft that we're talking about. So we do have a logical way of allocating these. So if we just think back to the first patient that you saw in the news item, Rebecca comes forward, and quite honestly, when she called for the first time, I had somebody walk in my office and say, "There's a girl who's already donated her kidney, and she wants to donate a part of her liver to somebody she doesn't know." And I thought, well, she sounds nuts. So, that just didn't even think about it. And she called back, and no, she's really serious about this. And then she wanted to know how long would she have to wait after donating her kidney. And I said, well, at least a year. I'm just completely making it up on the fly. And she called back at the year and basically said, this is something I'm going to do. I'd like to do it at the University of Colorado with you, but I'm starting a PhD program. And if you don't want to do that, then I'm going to go somewhere else. So then we really looked at it and said, okay, she's 24 years old. She's already donated part of her kidney. Her motivation is to make the world a better place. She works at this very posh ski place, Yellowstone or something like that, up in Montana. She's got a very supportive family. Her mother was a previous kidney donor. She's 5'8". She weighs 81 kilograms. She has a little bit of complicated anatomy in that she has 2 portal veins to the right lobe and 1 to the left. If we were going to do, a right lobe, which is the first question, is that a reasonable thing to do? I felt at the time, we had never done a non-directed donor before, and I felt that a 24-year-old girl who'd already donated her kidney, to me, doing a right lobe donation was pushing it into the unacceptable range. That's not necessarily what others might think, and it's not what we do today. but I thought it was appropriate at the time. Instead, we said, well, what if she donated her left lateral segment, 20% of her liver volume? Okay, then we could transplant this 1-year-old baby with biliary atresia who doesn't have any other means of transplantation. It would be a good sized graft. The anatomy is appropriate. It's less risk to her, the minimal risk to her. And so we decided, yes, that was acceptable. And so that was our first patient. That's how we moved ahead with her as our first non-directed donor. If we look at the case that Whitney was talking about with Raynette, she had a potential donor who was 39 years old, was in the Peace Corps, prior kidney donor again, stable job, worked as an environmental engineer, so very educated, single, doesn't have any children. Her parents were supportive of her choice. She's 5'5", 58 kilograms. Her left lobe had complicated anatomy in that we would have to deal with 2 arteries, 2 small arteries. So, but her right lobe looked good from the anatomy standpoint. It was a single artery, single vein, single bile duct, and it was 704 grams. So our recipient was 70 kilograms, and our general rule of thumb is we need about 1% liver weight to body weight. So a 70 kilogram person would need about 700 grams of liver tissue. So this was actually perfect. And so in this particular case, we felt that, you know, given the actual situation with the donor and the anatomy and the fact that she certainly understood the risks, that it was reasonable to proceed ahead with right lobe donation. So now I'm going to turn it back to Whitney to let you see what the results of our non-directed donor program has been.
Yeah, so, you know, Dr. Pomfret really just talked us through her initial decision making with Rebecca. And once Rebecca came in, I do not know what opened these floodgates, but we have had just an amazing number of people come forward to the center and say, hi, I want to be evaluated to donate my liver. I want it to go to anybody who's in need. And Angela was that other person that we had after we had had a little bit more experience, and kind of why you felt comfortable with the right lobe was because we just had more time by that point. So we now have exactly 5 years of experience with this. Over the past 5 years, 26 donors have been approved and donated a part of their liver to people that they did not know. Now, 23 were actually ruled out of the 51 people that approached us. And so I do want to kind of emphasize that at least starting out early, we were quite conservative. And we have started to liberalize some things over time, but of the 23 people that were ruled out, 12 were for medical reasons, incidental things that we found during their evaluation, perhaps like a psychosocial situation where we just didn't think that this was the best thing for this potential donor at this point in time. 4 people withdrew because they learned more about it and recognized this was not something that was really in their best interest. And interestingly, in 2018, we approved a donor to donate who was an AB blood type, and there was no size or blood type compatible recipient on the list. And just thinking back to the beginning of this talk where we're talking about like supply and demand, you know, demand is just really outpacing supply here. To flip that paradigm is unheard of, really unheard of. So of these 26 people that were approved for donation, 19 were allocated to children and 7 to adults. Who are these people? Our experience, and this is very consistent with the University of Toronto experience also, is that they're highly educated. They're all generally working as very successful people. The few that are not working were in between things. Our experience is really unique in that we have almost 50% of our non-directed donors who have been prior kidney donors. 2 of our non-directed liver donors have actually gone on to donate a kidney a year after they've donated their liver. And so this population of people is just really remarkable and so inspiring to work with. Here in Colorado, there all Caucasian, which I think is probably just more of a reflection of the general population around us. There's a lot of females that do this, and these are young people. We are also just trying to get a better understanding of who these people are from a personality perspective. This helps us so that we kind of have a thumbprint of what's kind of a normal non-directed donor that we're looking at. That doesn't mean that people have to fit within this thumbprint. It's just us trying to understand what motivates people and who they are. So this is using a personality assessment inventory, which is a very well-established test that our psychiatrists do. This is called positive impression management. And so this basically reflects, the blue line, by the way, are kidney donors, and then the orange line are our non-directed liver donors. This basically shows you, these are people that tend to think of themselves in a positive way. And over here, this is treatment rejection, it's called. And so these are people who tend to see themselves as medically healthy, not needing a lot of doctor follow-up. And so those are kind of our typical personalities of donors. And here in the middle, these are these clinical scales that would help to identify people who maybe have anxiety, depression, some borderline features. And these are all extremely low. And our outcomes for our non-directed donors are excellent. And one thing that we did want to look at, aside from just medical outcomes, was how do these non-directed donors do over a longer period of time? What is their quality of life like? And so we've asked them questions about quality of life based on a well-established questionnaire called the SF-36. We also did this work with a couple other centers, pooling all our non-directed donor information. And each of these points is a domain for how that person is functioning from a quality of life perspective. The gray is where the general population tends to be, a general healthy population. And this dotted line are our non-directed donors. And so the farther out, basically, the better that your quality of life is and the better that you're functioning. Our non-directed donors, we have never had anybody approach us to say, I regret this. In fact, it's really the opposite. They say that this really changed their life and their perspective on life a lot. We've also, because these non-directed donors are going to pediatric recipients overall, we've tried to look at our pediatric, our neighbors waitlist program and see just what influence have these people made. And they really have flipped that supply and demand paradigm, which is just amazing. So if you look at the children's waitlist over time, this purple line is really the slope of what the children's waitlist was doing. And this red line is the start of the living donor liver transplant program at the pediatric hospital. Only one pediatric living donor liver transplant took place here before Dr. Pomfret started. And she's really been just such a champion of encouraging this across the street. And then this green line is the slope of what the wait list is doing at the start of the non-directed program. So at the end of, or in January 2020, there was one patient on the wait list at the pediatric program. And that was a very unique situation. That patient's insurance was only allowing for deceased donor liver transplantation and would not allow for living donor liver transplantation. So that was continuing to be petitioned. And the next year, the insurance changed their mind, and that patient's father was, just waiting to do that. And so he was transplanted immediately. So really, we have the second largest published cohort of non-directed donors in North America. It's eliminated the pediatric wait list. We prioritize to pediatric recipients, and that's a programmatic decision. UNOS, our national organ allocation, really directs deceased donors, and certainly MELD and using medical urgency is most appropriate on a national scale. We do that here also. It's just that it's not nationally regulated the same way. So we had to really establish that protocol for how we would allocate. And we especially pay attention to patients with who are under the age of 1. Small adults are now benefiting from this program, where a left lobe or sometimes a right lobe is used to help small adults. These tend to be females, and I showed you at the beginning that females are really underrepresented on the wait list also. And then I just want to mention, what are the future opportunities here? So in kidney, this has been going on for a long time. There are paired exchanges and there are chains. A paired exchange would be when a donor and a recipient that are usually related to each other come forward and want to donate. And then another pair would do that also. But for some reason, that initial pair, that donor and recipient, aren't compatible. Most commonly, that's because of blood type compatibility. And so instead of turning that pair down, you would say, can you please go on the sideline and wait while we go through our other pairs and see if there's anybody willing to make these switches for you. So here in recipient 2, in this recipient 2 pairing, you see this person who's blood type B is compatible to give to this recipient with a blood type AB, but they were approached and basically asked, even though you're compatible to donate to your mom, would you be willing to donate to this stranger, and then their donor could donate to your mom? And that way you're not only helping your mother, you're helping somebody else in need. So that would be a paired exchange. That has been something that's reported in case reports in the liver transplant literature. So it's only happened a few times. We've been waiting for the right pairing for this, and it hasn't worked out to date at our center, but it's something that we're constantly looking for. The other thing that I'll just mention that happens in kidneys a lot is when a non-directed donor comes forward, they can donate to one recipient, and if that recipient has a donor, that donor then donates to another recipient, and it basically can set off a chain reaction. That's something that I would love to see happen in liver transplantation also. I think from a practical perspective, what's held us back is that, remember, there are a lot more people waiting on dialysis for a kidney transplant. So you have a larger pool of people to work with, whereas in liver transplantation, there is no dialysis. There's just people are either going to be transplanted or pass away. And so your pool of recipients is changing a lot faster. And this is something that does need a little time to set up. And so I think those are our limitations right now. Something that is really exciting that will help us in terms of volume and numbers is that UNOS has created a paired exchange program nationally. There are a few centers that are participating in this, and the idea would be if we can find a good paired exchange with another transplant center, we would ask a donor to potentially even travel to go donate their liver to another recipient while that recipient's donor comes to us. So these are just future opportunities that are happening. What's making that possible is that they have funding from, I believe, like a private donor who has who's donated money to help with donors flying and staying in hotels and things like that. So, just to summarize, the waitlist reflects a limited resource allocation based on MELD sodium is not perfect. Living donor liver transplantation offers access to transplant with excellent outcomes. It decreases the donor pool, it increases the donor pool, improve recovery, optimizing timing of transplant. It has equivalent survival compared to deceased donor, and altruism is just really highly prevalent in Colorado, and as a result has eliminated the pediatric wait list. And these are just pictures of a lot of our donor and recipient pairs. I do just kind of want to mention a couple of them because I want you to know how much there's just such a strong belief in living donor liver transplantation here. So Lindsay is actually one of our physician assistants who works in the hepatology department. She donated to her mother many years ago who had PSC. Dr. Hillary Yaffe is a physician who, during her surgical residency, donated to her father with PSC. And this is an amazing twist of fate, but her donor surgeon was Dr. Pomfret in Boston, and her father's surgeon was Dr. Pompicelli, Dr. Pomfret's wife. husband, whoops. And then after Hillary completed her surgical training, she actually came out here and trained under Dr. Pomfret. And so she's the first living donor liver transplant surgeon who has also donated a part of her liver. And these are some of our early pediatric recipients. Aaron was a non-directed donor, and Jeremy and Joel met each other through church. And these are just, yeah, they've just been really amazing experiences for all of us.
Dr. Jackson, Dr. Pomfret, thank you very much. This is brilliant and inspiring. This is a really amazing talk. Thank you. Dr. Jackson, I know you had questions for Dr. Pomfret since she is a world expert on some of these things. Do you want to start with those and then we can go to questions from the audience next?
Sure, I would love to. I love picking her brain. Okay, so one of the things in terms of history, Dr. Thomas Startzel was the person who did the first liver transplantation. And something that I've heard is that he really did not support the idea of living donor liver transplantation. And, I just wanted to know, why do you think that would be? And do you think he would still hold that same belief today if he was here?
Well, he was very much against it. In fact, at one of the early meetings of the American Society of Transplant Surgeons at the Drake Hotel in Chicago, there was almost a fist fight that broke out, seriously, between him and Christoph Brulch, when Brulch was just talking about the concept of living donation. Tom Startzel felt that the risk was just totally unacceptable to a healthy person. By the end of his career, he had embraced it and, had hired somebody who was very aggressive with living donor liver transplantation. And obviously living donor kidney transplantation has been going on for a very long time. But, he did embrace it in the end.
And something that I really struggle with as a transplant hepatologist is if living donor liver transplantation has such excellent outcomes and donors don't regret this, and we're just so thorough in evaluating our donors, what are the barriers to the growth of this? Why can't we eliminate the wait list in the United States?
So it's very interesting because this is where you see a complete dichotomy between East and West. So in the East, Asia and countries in the East, deceased donation has been illegal in many of those countries, and so it's not an option. And so it was really our Asian colleagues who really pushed the envelope in terms of taking this from a pediatric operation, which everybody, felt pretty comfortable with, to expanding it to adult living donor liver transplant. In the West, so Western Europe and the United States and Canada, there is a deceased donor, large deceased donor programs that do the majority of the transplants. And for whatever reason, any living donor liver death that has occurred has had enormous media coverage, enormous. And it's to the detriment of the entire field. I actually am a person who experienced having a donor death. And I'm still very passionate about doing this because the reality is, under the best of circumstances, in the best of hands, you can never make risk zero. But the number of transplants that we're able to do that otherwise wouldn't happen because of living donation is what drives me to do that. And quite frankly, the donors themselves who contacted me.
Yeah. Dr. Pomfret, Dr. Jackson, I want to give Dr. Chopra a chance to ask one question. He has one on his mind as well.
Yeah, thanks, Dr. Connors. Dr. Connors and I were geeking out a little bit, Liz, when we were hearing your talk, because we remembered a textbook from college written by the evolutionary biologist Richard Dawkins about the selfish gene. and about how evolution has taught us to preserve our genes by being in some ways protective about our offspring, about who we give to, who we don't give to. It's actually against our evolutionary interest to give away parts of us because there's no value to that. Is there an altruistic gene? Is there genetic studies of people who do this?
Well, there's some studies that are coming up now of people looking at MRIs and I don't know anybody who's working at the gene level, but I think it's probably only a matter of time. But you certainly have different patterns of the way the MRI lights up in a person who's very altruistic or a person who does something spontaneous. You're standing on the beach, you see someone drowning, you just run in to save the person. And it appears to be something in the hippocampus. I'd be lying to you if I said I knew what I was talking about with the brain, but I do think that there's probably something because there is a similarity that exists between these living donors and especially non-directed donors. They are typically people who are just have this moral obligation to help people. Now, I can tell you that the moral obligation seems to be stronger here in Colorado than it was in Boston, and quite honestly, stronger than anywhere in the country. There's no other place in the country that has this number of non-directed donors. So, what is it about Colorado? I don't know, but it is unique. And so I would probably say, yeah, there probably is something to this. We've done a lot of work. I had done work prior to coming here on ambivalent donors. So it's very, very interesting because there are groups of people who will donate, but they will tell you that they don't like the recipient. So it's typically brother to brother or son to father. Okay. Women generally do not donate to people they don't like, even if they have to talk themselves into liking, my brother's always sort of been a mess, but he had this and this and this, and so women don't generally donate to people they don't like. It's interesting that, you can find this other population where, two brothers really don't like each other. And yet the one feels a moral obligation to do it because it's his brother and he wants to help that wife and the family and whatever. It's a different way of thinking. But it's very interesting to look at.
This has been fantastic. Yeah.
A selfless act that inspires thing. No, I was going to say selfless act that's inspiring, and maybe it's in the water, Liz, and that's good.
Maybe, or the air or something, but it's definitely different. I mean, it was almost bizarre, when I kept getting this sort of parade of people walking into my office saying there's another person who wants to donate part of their liver, kind of like what? I don't know. In Boston, yes. Firefighter, police officer, this kind of thing. But, Aaron and Manny, I mean, this guy is a business person who really moved out to Colorado because he was into bike racing and does all this bike racing, and within the first year of moving here came forward and wanted to donate a portion of his liver. So, I've obviously changed some of my cynical thoughts of she must be nuts to realizing that there are really good people in this world that I just didn't realize existed.
The other thing I'll just add from looking at those personality assessments that I do think is consistent with Colorado is there's this element of people who like to take a little bit of risk for a life experience, and also want to help somebody at the same time. So in some ways you might say, maybe this isn't like a truly selfless act, maybe this is kind of for an experience. And that does seem to kind of draw some people in. So a lot of our donors, like Manny, is doing the triple bypass race, they're doing really pretty extreme physical things. A lot of the men, we have like an Everest climber. We had a guy who jumps out of planes. The women don't seem to be as physically risk-taking. They tend to be people that just truly had heard or had an experience where somebody needed a transplant, heard how it went, and said, you know, how can I not do this?
I think the other thing about Colorado is there's two things. We get a lot of donors from down in the Colorado Springs area, and that's high military and very high Christian. You know, I've had a Navy SEAL who was a donor. I've had numerous people from the military who have been donors, along with a lot of these people who have connected through church or whatever.
Great. I appreciate this. We could do another hour on this. It's fantastic. Dr. Pomfret, Dr. Jackson, I will say for our audience, we have a number of questions that I think are practically relevant, like how do I do this and where do I make contact? And we didn't get to talk about that. So I'll send those to you so that we can push those back out to our audience afterwards. But
okay,
we
have a website, UC Health Living Donor. That's the best way to contact us for questions too.
Well,
we'll get it all written down right next to your talk that we'll post online. So not a problem. So great.
Thank you.
Thank you both very much. We really appreciate it.
Thank you. Bye.